A very good morning to all. I am Arpita from the IJCP group. In recognition of the World Brain Day, I welcome all to the webinar on multiple sclerosis, an overview dedicated to increasing awareness and understanding of multiple sclerosis. Multiple sclerosis is a chronic neurological condition that affects millions of people worldwide, impacting their daily lives and overall well-being. This session will provide a comprehensive overview of the multiple sclerosis, including its symptom, diagnosis, treatment options, and the latest research advancement. Now, to address this very crucial topic, we have with us none other than Dr. T.K. Banerjee, sir. Sir is a medical director and chief consultant neurologist at National Neurosciences Center, Kolkata. He has more than 30 years of experience. Dr. Banerjee is a member of the Neurological Society of India, Indian Medical Association, Indian Academy of Neurologists, and many more. He has many national and international publications and is actively invited as a guest speaker in scientific meetings, CMEs, worldwide conferences to talk about the neurological disorders. So, with this very brief introduction of Sir, now I would request him to please start with his presentation. Over to you, sir.
Good morning, friends, and my warm greetings to all for this World Brain Day. I've chosen the subject of multiple sclerosis as a lecture for today. The reason being that multiple sclerosis affects individuals in the most productive years of their life, between the age of 20 and 50. And if these patients are left untreated, then gradually they become disabled, wheelchair bound, and again ultimately it can become fatal after a few years. Nowadays, we have a treatment available for this multiple sclerosis, but that needs early diagnosis of these patients. The doctors have to be aware of this particular disease, multiple sclerosis, and diagnose them as early as possible so that a prompt treatment can be instituted right at the beginning. If that is done, then we can actually arrest the disease at that point and the patient can have a full healthy life. So it is extremely important to be aware of this particular disease, multiple sclerosis. So multiple sclerosis by definition is a chronic immune-based inflammatory demyelinating disease of the central nervous system. Central nervous system means brain and spinal cord. It is a white matter disease. That means it affects the axonal part of the nervous system. It has a multitude of clinical presentations. So, historically speaking, multiple sclerosis was first identified by none other than Jean-Martin Charcot, who is called the father of neurology. So he actually used to have patients of various neurological disorders. At that time, neurological diseases were not that people didn't know about this disease. So in his hospital in Paris, in Salpêtrière, he used to get patients, have a thorough examination. At that time, the examinations were crude, but he refined those clinical examinations. And then when the patient used to die, because at that time, many of the neurological diseases didn't have a cure for it. Then the cadavers were there. In the cadavers, he found in these patients, they have peculiar scarring of the nerves in the brain and spinal cord, which was in French, la sclérose en plaques. And from that point onwards, he tried to identify the various clinical manifestations and then came up with this clinical entity, multiple sclerosis, way back in 1868. Now, science has advanced a lot after that, and now we know fully well what this disease means. And these are the clinical presentations of multiple sclerosis. They may present with acute onset blurring of vision in one or both eyes because of optic neuritis. They may present with eye movement disorder or diplopia because of the plaques in the brainstem. Myelitis is another kind of presentation with acute onset paraplegia and sphincter disturbance. Cerebellar ataxia with dysarthria and intention tremor is another way a multiple sclerosis may present. Sensory loss on one side, pain and paresthesia Apart from that, acute onset hemiplegia like stroke, this multiple sclerosis may present with trigeminal neuralgia, bilateral facial weakness. Another thing people didn't know earlier, but nowadays we know that patients with multiple sclerosis also have some kind of cognitive dysfunction. They're slow thinkers, they make mistakes in their judgment, and they can't do the arithmetic calculations that speedily as a normal person. And the memory also gets affected in many of these individuals. Another manifestation is the profound fatigue. Many of the multiple sclerosis patients say, I am otherwise all right. I feel extremely tired all the time. Fatigue, and at the advanced stage of the disease, one can have epileptic seizures as well. This is a central nervous system disease, as I have said. And the characteristic is that there is a dissemination in space and time. What does it mean? First, a clinical event may occur with optic nerves being involved. So it's optic neuritis. Then in another occasion, another episode happens with paraplegia. So the distribution of the disease is disseminated in different anatomical spaces at different time points. So different time points, the different anatomical areas of the brain or spinal cord gets involved. That's why it was earlier known as disseminated sclerosis. So dissemination in space and time is a hallmark of multiple sclerosis. The common age of occurrence is 20 to 50 years. It occurs predominantly women, 2 to 3 times more than men. And this is a disease, actually, it is mainly seen in the Caucasian population of Northern European ancestry. And that's why people thought that multiple sclerosis is not happening in India. That was the thought earlier, around 50 years ago. And then they identified 1 or 2 patients. And now we can see many more patients coming with multiple sclerosis. So if you see the prevalence rate in the world map, as I said, certainly in the Western population of North America and in the Western industrialized countries of Europe, this disease is mostly prevalent. It occurs in the prevalence of 1 in 1,000 population suffer from multiple sclerosis. And um, here on the other extreme, you can see China. It is extremely rare. It is 0 to 5 per 100,000. But India sits in between. In India, the prevalence of multiple sclerosis is somewhere between 5 and 20 per 100,000. I would say more towards 20 than 5. So India, we are seeing more and more patients of multiple sclerosis, and that's why it is necessary for us to diagnose this disease early, because now we have the treatment available. So, what is the current status in India of multiple sclerosis? 30 years is the average age of a multiple sclerosis diagnosis. 63% of them are women. The current estimate, and that was again a few years ago, it was said that 145,800 people are living with multiple sclerosis, and each year 6,500 new cases are getting added. You can say roughly around 542 cases of multiple sclerosis diagnosed across India every month. Among children, around 4,000 children under the age of 18 are living with multiple sclerosis. And most of these patients of multiple sclerosis, 68,000 here, are of relapsing remitting type of multiple sclerosis. I'll come to that. Now, what are the subtypes of multiple sclerosis? 80% of them have a relapsing remitting course. And relapsing remitting again converts to secondary progressive. Now, 20% of them have a primary progressive MS. I will elaborate on it further. Now, more than 80% of the MS have relapsing remitting course. What does it mean? It means the patient present with one definite attack of neurological deficit. Suppose the patient presents with paraplegia. And then after 2 3 weeks or around a month's time, his neurological deficit resolves. And then after, say, 4 months or 6 months, he comes with another neurological deficit. That is, with optic neuritis. Again, that resolves. Third time, the patient present with ataxia, unsteadiness of gait because of cerebellar involvement. So there is a relapse of neurological deficit, then it resolves or remits, and then again another event occurs. So there is a event occurring and there's a remission which may be full remission or complete remission, or sometimes a residual deficit remains, that means an incomplete remission, and then another episode comes. So this is the pattern, the characteristic pattern of multiple sclerosis in 80% of individuals, and that is why it's called relapsing remitting multiple sclerosis. Now, clinically isolated syndrome. The clinically isolated syndrome was the first clinical episode of this relapsing remitting multiple sclerosis, the first episode. And the episode may be in the optic nerve, in the spinal cord, in the brainstem, in cerebellum, is extremely unpredictable. So, first clinical episode of inflammatory demyelinating disorder of central nervous system is called clinically isolated syndrome. To be termed clinically isolated syndrome, the episode should last more than 24 hours and occur in the absence of fever or infection with no clinical feature of encephalopathy. This is a full definition. The reason this clinically isolated syndrome has become very important, I will deal with it further in the therapeutics, because they have to identify the first episode when it occurs, say optic neuritis or paraplegia, myelitis. Is it the only episode that has happened to the individual, or whether these patients will ultimately convert into multiple sclerosis, will have multiple episodes in future? This is extremely important to know at the occurrence of the first stage, whether it is isolated optic neuritis, whether it's an isolated case of transverse myelitis and it resolves and it doesn't recur again. So this is extremely important to know at this stage to initiate treatment, to see whether the treatment for multiple sclerosis would be considered at this stage. So, clinically isolated syndrome has become extremely important in today's treatment. Secondary progressive multiple sclerosis, after this relapsing remitting course spanning from 2 to 40 years, these patients go into a steady progressive phase of neurological damage. There may be superimposed relapses on this and minor remissions on that, but the bottom line is there's an undercurrent progression of the disease over time. And then it is called a secondary progressive multiple sclerosis. In contrast to what I have said, around 10 to 20% of the patients have a primary progressive multiple sclerosis. Here, right from the onset, it doesn't take the relapsing remitting course, it has a steady progression of the disease from the onset. There may be a few relapses on top of this, but the undercurrent progression continues right from the beginning. So, this is primary progressive multiple sclerosis. So this is a schematic diagram showing in 70% of the cases, there is a relapse and remission. As gradually time goes by, the remission is incomplete. Earlier on, it was a complete remission. And then after a few years, they go into a progressive phase, which is called secondary progressive phase, following the relapsing remittent stage. That happens in 70%. In 10% of this relapsing remitting stage, there are always relapse and remissions throughout their life. They don't go into a progressive phase. They are called benign relapsing remitting multiple sclerosis. But people don't know right at the beginning which particular treatment an individual will have, whether they will go into secondary progressive or whether ultimately it will be a benign relapsing remitting multiple sclerosis. So it is not possible to say, but whenever you identify a case of multiple sclerosis, it's better to treat them immediately. And the primary progressive form of multiple sclerosis constitute 20%, where there is a progression right from the beginning. Now I have expanded this secondary and primary progressive figures more. You can see in primary progressive multiple sclerosis, right from the beginning, there is progression. There may be phases where the disease remains static at a stage, but then again there is progression. There may be a small relapse there, but then the relapse sort of has an incomplete remission and then again it starts progressing. There are areas of plateaus where there is a status quo is maintained, and then after a couple of months, it again progresses. This is the nature of primary progressive multiple sclerosis. In contrast to it, in secondary progressive multiple sclerosis, there is progression, and there are little bit more relapses on top of the progression, because earlier on these patients had the nature of relapsing remitting multiple sclerosis. So relapses do occur on top of a progressive phase of the disease. So the pathophysiology of multiple sclerosis. Multiple sclerosis, in the central nervous system, this disease is there. There is inflammation followed by demyelination in the central nervous system, and ultimately this is followed by neurodegeneration with neuronal dropouts. And that is neurodegeneration leads to this progression of the disease. The body's own immune system attacks the central nervous system, and that's why there's inflammation. And the inflammation actually destroys the myelin sheath, the protective covering of the nerves in the brain and spinal cord. The myelin sheath is ruptured and the demyelination occurs, which leads to the neurological deficit. Then, after some time, the remyelination occurs. The new myelin sheath is formed when the neurological deficit normalizes, but as time goes by, this demyelination is not always followed by remyelination, and then the axons get damaged. The degeneration of axon occurs, and when the axons start getting damaged, the neurodegeneration is happening, and that is when the progressive phase comes. So it has three types of pathophysiology: inflammation, demyelination. Demyelination may or may not be followed by remyelination. If remyelination is not there, then the degeneration sets in. So let me show you in this cartoon here. Now, some cells, the T lymphocyte cells and B lymphocyte cells, which are there in the circulation, some of these T lymphocyte and B lymphocyte cells become autoreactive. And the reason for them being autoreactive, we're not sure what triggers on this process of autoreactivity. There are genetic factors, maybe some environmental factors which are being thought of. There may be virus, EB virus, Epstein-Barr virus is one of the incubating virus. They're saying vitamin D deficiency in the environment in that particular individual may be one of the promoting factor of this disease. So there are a lot of other viruses and all these things, but people are not sure what are the definite causes which makes some of the T and B lymphocytes becoming autoreactive. Once they become autoreactive, they migrate through the blood-brain barrier into the central nervous system and causes inflammation. They draw in the various killer cells or the macrophages. They activate the microglia that also destroys the nerve cells. They generate antibodies and cytokines. So they all home into the myelin sheath of the nerves and destroy the myelin. So there is demyelination. The myelin sheaths drop out. And the myelin sheath drops out after some time, they say get restored. But if they don't get restored, they go into this phase of neurodegeneration. Myelin sheath drop out, then the axons are degenerated and the whole nerves are damaged. So once the whole nerve is damaged, there is no question of reversal of the process. The patients ultimately go into progression. They don't go back. So irreversibility ultimately happens. So T cells and B cells, that means T lymphocytes and B lymphocytes, are the real instrumental in this pathophysiology of multiple sclerosis. They work independently to cause the disease, and they sometimes crosstalk or collaborate with each other and destroy the nerve cells. So T and B lymphocytes are the main culprits, autoreactive T and B lymphocytes, in the process of multiple sclerosis. So, what are the essential diagnostic investigations of multiple sclerosis? The most important investigations now absolutely essential in the diagnosis is MRI scan of brain and spinal cord with contrast. There are other complementary investigations that also has to be done. One is a CSF analysis to look for oleoclonal band and the evoke potential studies. So, cerebrospinal MRI scan with contrast has become the most essential and mandatory investigation if you want to diagnose multiple sclerosis. The advent of the magnetic resonance imaging or MRI has been the real diagnostic breakthrough in the realm of multiple sclerosis. What happens in multiple sclerosis? There are T2 hyperintense lesions, and these T2 hyperintense lesions are strategically placed at different parts of the brain. That is very important. Where they should be, they're in the juxtacortical region, just on the cortex, just abutting on the cortex, just below the cortex. They may happen in the periventricular region, you see, around the ventricles. There may be plaques, T2 hyperintense plaques, in the infratentorial region, that means in the cerebellum and in the brainstem. And there may be these small segment plaques happening in the spinal cord. So it is disseminated in the brain and spinal cord, but there are certain particular vital areas where they should be discriminated. The pattern of distribution of these lesions around these points are very important to diagnose or that these are plaques of multiple sclerosis and nothing else. In the brain, when they're around the periventricular region, they take a peculiar orientation. They are orientated perpendicular to the surface of the ventricles. So they are called, and it is there are figures where they are more visible. They are called the Dawson fingers. The Dawson fingers is one of the very interesting and hallmark of multiple sclerosis MRI scan. And dissemination in time also happens. That means if you have seen a plaque here in the T2 hyperintense lesion in the brain in the baseline MRI scan, say after 6 months time, if you do a repeat MRI, if you see multiple new plaques have come in at the same in the brain at that particular slice of the brain. So there are new lesions coming in at different time points. So this is another very characteristic in multiple sclerosis MRI. When you do a contrast, these plaques or what I was saying are demyelinating plaques. But when the inflammation occurs, the first phase, the demyelination is not yet occurred, then you can see in the contrast examination, as the arrow points out, the new lesion only comes up when the contrast is given. Suppose in the brain, it is, you don't see it, but when you give a contrast, a new lesion is lighted up. So that lesion happens because of inflammation of that nerve. So all these features very strongly points that this is a case of multiple sclerosis. In the spinal cord, as you can see, they have small segment demyelinating lesion. The small segment means there's a large segment demyelination. That means it extends over three vertebral areas. If it is over three vertebral areas, then you can say it's a large segment demyelination or hyperintense lesion. But there is a small segment hyperintense lesion which is confined to one or two segments only. Then there are small segment lesions. These are very characteristic of multiple sclerosis. Another important thing is that these lesions are eccentrically placed, not in the middle and at the edges of the spinal cord. So eccentrically placed small segment lesions are cardinal features of multiple sclerosis plaques. So apart from that, CSF analysis is also very important. Because of the inflammation in the central nervous system, there is an intrathecal synthesis of immunoglobulins. Immunoglobulins are produced. And a particular band, because of the production of immunoglobulins, are called oleoclonal bands. So oleoclonal band, if we identify it through our method, we call it isoelectric focusing method in the CSF. We identify the oleoclonal band, which actually means there's intrathecal synthesis of immunoglobulins. It happens in 90 to 95% of multiple sclerosis. It's one of the diagnostic feature. And if you just not see the oleoclonal band, even intrathecal IgG production, if you see non-specifically, this happens in 70 to 90% of the patients. Now, this general production of oleoclonal band is not absolute 100% diagnostic of multiple sclerosis, because that only means a inflammation in the central nervous system is going on, and other chronic inflammatory disorders can have oleoclonal band, but this is only in few percentage of cases you can identify in other conditions. But in multiple sclerosis, 90 to 95% will have oleoclonal band positivity. The other investigation, the neurophysiological investigation called evoked potential studies were done. There's a visual evoked potential, brainstem auditory evoked potential, and somatosensory evoked potential. That actually is an indirect way of determining demyelination at different tracts. Of this, visual evoked potentials is most commonly utilized, and it determines indirectly the demyelination of the optic nerve. There are a whole host of differential diagnoses of multiple sclerosis. If we suspect a case of multiple sclerosis, there are other very similar disease to it which you have to differentiate it from. One is the NMO spectrum disorder, neuromyelitis optica spectrum disorder. There is another new entity which is being used here. It's called MOGAD. There are some ischemic. If there is a ischemic optic neuritis or ischemic myelitis, that has to be differentiated from an inflammatory demyelinating myelitis or multiple sclerosis. Sometimes you can get a simple transverse myelitis. It could be a monophasic illness. Transverse myelitis, it may occur after infection or without any infection, sometimes after vaccine. So myelitis myelopathy is another thing to be distinguished from. The infective process, various infective process giving rise to autoimmune disorders, is another thing we have to distinguish. So ischemic, autoimmune, monophasic, other types of myelitis, or NMO spectrum disorder, these are the things one has to exclude when you are definitively saying this is a case of multiple sclerosis. So here are the differential diagnoses on how to test them from the laboratory. As OCB is very important in multiple sclerosis, in neuromyelitis optica diagnosis, NMO IgG positivity is important in the CSF. In Sjogren syndrome or one of these vasculitis, one do SSA, SSB. These are, if those are present strongly, then this could be an autoimmune disease. SLE, systemic lupus erythematosus, there are a whole host of antibodies which you have to see whether it is strongly positive or not. There are other features of SLE that has to be ruled out too. So all these things you have to suspect and exclude before we definitely say it's multiple sclerosis. In neurosarcoidosis is another thing. You have to do ACE or look for uveitis, lung or skin involvement. There is a disease which is very rare in our country, common in the Turkish population, Japanese population, called neurobeshet's disease, where they have oral genital ulcers, cerebral venous thrombosis, and also this peculiar type of neurological deficit may happen. But the way of differentiating is that if you clinically find out there is oral genital ulcers, then in a particular population you do a HLA-B51. If that is positive, this is neurobeshet's disease. So think of all these differential diagnosis before we jump into the conclusion is multiple sclerosis. Primary CNS vasculitis is another thing which has to be ruled out. Sometimes if there is a strong index of suspicion, do a conventional angiography. We see the vascular irregularities in the cerebral vessels. So now we come to a very important part of the topic, and that is pharmacotherapy of multiple sclerosis. There are three arms of therapy. One is treatment of acute attack. Then there is symptomatic therapy. And third, the extremely important therapy, the disease modifying therapy to arrest relapse and disability progression of the disease. First, the acute attack. Now, in the relapsing remitting multiple sclerosis, as I've said, there is clinical event, and after a few weeks, the event gradually disappears on its own. But if you find the attack, you give a pulse methylprednisolone at the dose of 500 to 1000 milligram IV infusion daily for 3 to 5 days. And that helps to shorten the attack duration, expedite or hasten the recovery process. So when there is a relapse, give methylprednisolone at the infusion dose as I mentioned, and that resolves the disease. Sometimes the patients do not respond well to pulse methylprednisolone. In that case, you can go for plasma exchange. Symptomatic therapies of multiple sclerosis include certain drugs. Suppose the patient complains of profound fatigue. Amantadine or at better modafinil is a very good drug for the patient to overcome fatigue. Spasticity can be helped by baclofen, tizanidine, or botulinum toxin. If there's pain or paresthesia, the pain modulating drugs like pregabalin, gabapentin, or duloxetine help. If there is an uninhibited bladder, the patient has urgency of micturition, has to rush to the toilet. Oxybutynin, mirabegron, intravesical Botox injection. For detrusor sphincter dyssynergia, it is also another thing not very uncommon in multiple sclerosis. The Here the bladder wall contracts, but the sphincter is closed. So there is a lack of coordination between the contraction of the bladder wall and the contraction relaxation of the sphincter. That happens sometimes. You can see many advanced with the multiple sclerosis develop renal failure because they have a vesico-ureteric reflux due to detrusor sphincter dyssynergia. And their Botox injection of external urinary sphincter is helpful. There is one drug which has now come, which is dalfampyridine, 4-aminopyridine, and that has shown to improve the mobility speed in the case of MS. The way it works, it sort of blocks the voltage dependent potassium channels in demyelinating neurons. But the most important thing that has happened over the last 30 years is this disease modifying therapy. So this has been the game changer in the treatment of multiple sclerosis. In 1993, the new era of disease modifying therapy began with the FDA approved drug interferon beta 1b. Over the next 5 years, other interferons and glatiramer came into existence. So this is the time when people understood there is a way of arresting the disease by giving these disease modifying drugs. And now we have a wide range of disease modifying drugs available, which has really changed the landscape of multiple sclerosis. Now we aim at what? We aim at arresting the disease completely. And what do you mean by arresting the disease? We want to achieve NIDA 4, no evidence of disease activity, with 4 components being arrested: absence of confirmed relapse, absence of 6-month confirmed disability progression, absence of new or enlarging T2 lesions in the brain, and absence of brain volume loss. If these 4 are achieved over time, if we sort of survey the patients periodically, yearly, or twice a year, and see nothing of this has happened over years together, then you say we have with this particular medicine achieved NIDA 4, no evidence of disease activity, and that's what we aim at. So now the therapies, the earlier therapies that we used to have, they are called moderate efficacy therapies. They are helpful in around 30-40% of multiple sclerosis patients in achieving NIDA 4. And the earlier therapies were all given in the parenteral route, and they included the first drug, interferon beta 1b, then came glatiramer, interferon beta 1a, subcutaneous, all these are subcutaneously been given. But then interferon beta 1a intramuscular drug came into existence. And the last of this is the pegylated interferon beta 1a given subcutaneously. They're the parenteral drugs being used. Then after that, the oral route, the oral drugs have come into existence. This is teriflunomide and dimethyl fumarate. But these therapies are now called platform therapies. The moderate efficacy therapies, and now we have these high efficacy therapies. These high efficacy therapies have been found to be much more efficacious than the moderate efficacy therapies. 70% of the multiple sclerosis or even more are arrested by administering these drugs. Fingolimod orally is being given, but that is not that great a therapy. The natalizumab and alemtuzumab are very powerful um, drugs that has been used as high efficacy therapy for multiple sclerosis. And now we have the new group of drugs which are B lymphocyte depleter drugs, the rituximab, ocrelizumab, ofatumumab. These are the drugs. I'll talk about it a later bit. And then cladribine, another drug, orally, this has been given high efficacy drug. This is not available in India yet, but the others are available. So why people go for okay, I'll talk about this later. So these are the various therapies that are available now. The message is to identify the disease as early as possible, because suppose a patient is already having walking difficulty, uh, walking for 20 feet or something, that means he is advanced in his disease course. He has probably gone into a progressive phase, not only in the relapsing remitting phase. If we start treatment at that point of time, you may make a slight change in his ultimate outcome, but you cannot fully stop him becoming wheelchair bound. So later intervention may not be very beneficial. So you have to capture the patient early in the course of illness, right at the beginning. And if you intervene with your medicine at that point of time, the disease modifying therapy, you can make a substantial improvement in the natural in his course of illness. The patient may not ever become wheelchair bound and may lead a normal life, provided you have captured the patient and initiated treatment right at the stage or at the very early stage. So message is disease modifying therapy should be given as early as possible to really alter meaningfully the natural course of relapsing remitting multiple sclerosis. And there is where I talked about it, clinically isolated syndrome. When the first episode occurs, you have to do investigation in such a way that this is not an isolated case of demyelination. This patient is going to develop multiple sclerosis later on. And you initiate treatment of disease modifying therapy at that point of time. If you can do that, you'll be able to arrest the disease much better than if you give at a later stage. So the perception was you start with the platform therapies first, and then if we find the response is not optimal, you go for high efficacy therapies. Now you might ask the question that high efficacy therapies, even because it is better, why don't you start with high efficacy therapy? What actually happened, the high efficacy therapies are surely much more effective in arresting the disease, but at the same time, they have very serious adverse effects associated with it. Immunosuppressed drug, they may cause other problems. Platform therapies in that case are much more benign and safe and more favorable for the patients. So the practice that has been carried out all these years will start with platform therapy. And then if we find the response is suboptimal, then you should move on to high efficacy therapies. Platform therapies, as I mentioned, were interferons, which were and glatiramer, which were given parenterally, and the oral drugs were teriflunomide and dimethyl fumarate. suboptimal response, go to the high efficacy therapies. But the high efficacy therapy, the concerns where are important. The opportunistic infections. Because it are immunosuppressive drugs, the chance of opportunistic infection is high. If you give alemtuzumab, which is a very powerful drug, you can get the opportunistic infection of listeriosis for herpes infection. So you have to cover by giving antibiotics so that to prevent these infections from happening. But then again, many of these patients go into secondary autoimmunity, 50% of the patients, and that is ITP or renal and thyroid disease can happen in this sort of patient with this sort of drug. So one is a little bit concerned that if you start in with high efficacy therapy, maybe we'll end up with other problems. Natalizumab is extremely efficacious drug, but once you give natalizumab, you have to ensure annual MRI and frequent anti-JC virus antibody titer checkup. It is absolutely mandatory to do it because natalizumab has been found that it sort of activates the JC virus or what they call John Cunningham virus. Many of our individuals have John Cunningham virus latently placed in their brain. They don't cause any harm, but natalizumab brings down the immunity inside the brain in such a manner that those viruses can get activated. And if they get activated, it leads to a disease called progressive multifocal leukoencephalopathy, which is an incurable disease. So every year the MRI has to be monitored in these patients to exclude PML, and also anti-JC virus antibody titer has to be done. Because if the anti-JCV antibody index goes beyond 1.5, we have to discontinue natalizumab. 68% of the progressive multifocal leukoencephalopathy or PML cases occurred in those treated with natalizumab over 3 years. So if the patient, the initial JCV titer is negative, natalizumab is a safe drug to give, but then again you have to monitor whether they are becoming positive. If the patient has already positive JC virus, I did find out what is the titer. If it's a very low titer, you can still give it. But I think you should not continue this medicine for more than 2 years on these patients. Because suddenly if the index goes up, there is a high risk of them developing PML. So these are the potential adverse effects associated with high efficacy therapy in multiple sclerosis. But now we have a lot of data after disease modifying therapy over 20 years, 30 years. What people have realized and observed now that those patients who were initially treated with high efficacy treatment have a significantly lower risk of conversion to progressive multiple sclerosis or secondary progressive multiple sclerosis compared with patients initially treated with low efficacy treatment. Suppose I have started with platform therapy in the patient, then after a few years I have found the patient is not responding that well to it, moved on to high efficacy therapy. Long-term data will show that those patients have have a poorer outcome than those who have initiated high efficacy therapy right at the beginning. But the fact of the matter is, high efficacy therapy is also fraught with this potential risk factor. So, what we are going to do? So, the reason behind giving high efficacy therapy is that multiple sclerosis has the maximum inflammatory activity in the early part of the disease. And the later part is the degenerative phase. Once they go into degenerative phase of multiple sclerosis, the drugs will not have much effect because the disease modifying drugs actually arrest the inflammation. And the inflammation occurs in the early stage. So if you hit the inflammation hard early, then you may totally change the outcome of the disease over the next 10 to 20 years. So a lot of data has come about it, and this is one graph that has been given, and this is self-explanatory. Those who are taking initiated with low efficacy therapy or platform therapy after 9 or 10 years, they have some progression of the disease that has occurred. I mean, if they didn't have any treatment, they should have gone and died by that time. But they have become probably a little bit less mobile after 9, 10 years compared to uh, those patients who are on this high efficacy therapy. So the disability is more in those with low efficacy therapy than those with high efficacy therapy who had started high efficacy therapy right at the beginning. So this is now being uh, definitely been proven. So now this new revolution has come in our disease modifying therapy. These are called anti CD20 therapies. Now, CD20 antigens are uniquely placed on the surface of the B lymphocytes. On the surface of the B lymphocytes, these CD20 antigens are present. And now the monoclonal antibodies have been developed which work only on this CD20 antigen. So they selectively kill the B lymphocytes, leaving the T lymphocytes intact, leaving the plasma cells intact, and the precursor cells for B and T lymphocytes intact. And by doing so, they are found to be very high efficacy therapies in controlling multiple sclerosis, but at the same time, the side effect profile is far more preferable than the earlier high efficacy therapies like fingolimod or alemtuzumab or natalizumab. So the anti-CD20 disease modifying therapies are the talks of today. The one which is available and easily are affordable in our country is rituximab. That's been widely given to many of the patients of multiple sclerosis. But I think the far more efficacious drug, humanized form of monoclonal antibodies, which have come, one is the ocrelizumab and the ofatumumab. The price is higher. That's why people are not willing to take this drug. But those who can afford it, definitely these are advisable to take these drugs. But so these are the anti-CD20 therapies that has become one of the popular drugs in controlling multiple sclerosis. So what was the practice in the treatment of multiple sclerosis with disease modifying drugs? Earlier on, they observed the patients and then they found, okay, this patient is having multiple sclerosis. At that time, people used to have 1 or 2 or 3 attacks to make sure there's multiple sclerosis, and then they initiate treatment with platform therapies. Then once the one platform therapy is not effective, they sometimes switch to another platform therapy. And if that therapy also doesn't work well, then they go into high efficacy therapy. So that was the treatment paradigm that they used to do, the algorithm. It's like a pyramid. And then the next change is much more rapid escalation. Once they find the platform therapy, any platform therapy is not very effective, they move on to the high efficacy therapy. So that was the trend at that time. So, but after this, the entire algorithm has been changed now. Now the practice is more, once we diagnose a patient, unless the patient is showing very mild features, if it's a mild feature, you can still go for platform therapy. But if it's not mild, it is a little bit more aggressive. You should initiate in those patients with high efficacy therapy and go on. And sometimes people, after many years of high efficacy therapy, if the patient disease is fully arrested, they sometimes maintain them with platform therapies. Others say, okay, carry on with the high efficacy therapies. The patient is not having any problem. Now, with the anti CD20 therapies that we have, the side effect profile is so favorable that you continue this therapy all throughout life. So, what they call this pyramid of treatment algorithm has been flipped. There is a flipping of pyramid in our treatment algorithm, high efficacy therapy right at the beginning, because data have shown early initiation of treatment with high efficacy therapy is the best outcome in the treatment of multiple sclerosis. Now, whether will we at all be able to stop this treatment in a stable patient of multiple sclerosis. There are some data available that if this patient has multiple sclerosis, you have started treatment 3 4 years time. After that 4 5 years, patient is okay, you have stopped treatment. What happens? 24% of the patient has a relapse, 32% of the patients has a 3-month disability progression of the disease, and 10% have both relapses and progression of the disease. So they say that you continue the treatment. So DMTs were restarted in 42% of cases after 3 months of stopping the drug. So they again went back to the medicine. But now the data is coming that if somebody has reached the age of 55 or more than that, the chance of relapse or progression becomes much less. And there, if you see that last 5 to 10 years, the patient did not have any progression of the disease, you can stop the drug. But the patient has to be older, more than 55 years of age, not in those who are 20s or 30s, definitely not. So in that case, you can do that, but you should keep the patient under regular surveillance to see whether there is any worsening happening. So younger patients are the ones who definitely needs restarting the treatment. You cannot stop the treatment. In older patients, you can consider that. In the future therapy, there's one drug which will soon be available. They are called protein tyrosine kinase inhibitors. They sort of enter the blood-brain barrier and act on the activated microglia, cytokines, and all the inflammatory molecules that are formed, generated in the process of demyelination. So that is being attacked by these BTK inhibitors. So that is one drug which will get soon in future. So what are the future directions in multiple sclerosis? Um, so people are now considering those demyelinated nerves, whether we can foster remyelination and also provide neuroprotection so that all this inflammation doesn't affect the nerve cells. The research is ongoing on expediting the process of precursor cell differentiation to mature oligodendrocytes, because oligodendrocytes, if we can produce more, they are the ones who remyelinate the nerve cells. So future multiple sclerosis treatment will perhaps combine the highly effective disease modifying drugs, as I have mentioned, uh, treat them early with the highly effective disease modifying drugs, plus combine them with drugs that target the disease process in the CNS or enhance reparative process. So our future approach in multiple sclerosis therapy will be go beyond just the flipping of the pyramid. Thank you very much, and I end my lecture with warm greetings to all of you. Okay.
Thank you, sir. Thank you so much for such an elaborate description of the topic. The presentation was indeed beautiful, and I hope there will be no questions after this presentation. Still, I would like to request all our viewers, doctors, if you have any queries, please let us know. I will read them on your behalf. Sir, there is one question that has come. That is regarding patient management. So, how to address and counsel patients who have sclerosis and who face issues such as fatigue, mobility issues, cognitive impairment in their daily lives. So, how to deal with such patients?
All right, that's a very good question. Actually, as I said, the fatigue is a part of the illness, and you can combat this with certain drugs like modafinil. I found is very useful to improve the fatigue. Sometimes the fatigue also happens in these patients because of associated depression. Many of these people get depressed because of the illness. So if you give antidepressant drugs, that sometimes help. And the disease itself gives rise to fatigue. So modafinil or some cases amantadine do work in those cases. Um, Cognitive dysfunction is another very interesting topic. Now, people say that this cognitive impairment is not benefited by giving the drugs for Alzheimer dementia. We have drugs for Alzheimer dementia which we give, but here those drugs do not help these patients. We don't have a specific drug to help the cognitive dysfunction in this patient, but the idea is if we treat the disease as a whole, the cognitive dysfunction will also be kept under control.
Right, sir. Right, sir. Thank you so much. There is another query. Sir, how do you monitor the progression of sclerosis in patients, and what are the key indicators that suggest that severity is increasing?
Mhm. Yeah, that is why we always monitor the patients every 3 months. Or we ask the patient whenever they find there is a new symptom happening, do report to us. So every 3 months, we have certain parameters. We clinically examine the patient. There is something we call see the walking speed, the 25 feet walk. We ask the patient to walk 25 feet. If they find the walking speed is deteriorating significantly, then we say the mobility is getting affected. Also, we ask the patient whether new symptoms are coming. So this is how we can. Another thing is we do a 9-hole peg test. We see the coordination of the movements in the hands. So clinically examine the patient every 3 months and see whether there is any clinical progression of the disease. So clinical progression we monitor clinically and also from the patient's history. Patient also says that I cannot do or become active as I used to be few months ago. So this is a way to see whether the disease has progressed, underlying disease has progressed.
Right, sir. Right. Thank you so much, sir. Sir, there are no more queries for today. Sir, I would like to deeply appreciate and thank you for the outstanding presentation. And sir, it was such a complex topic, but with your expertise and through the clarity that you have explained it, it was really impressive. Thank you so much, sir. And of course, I would like to thank all the audiences for attending the session, for putting up their queries. Thank you all for making it a successful one.
Thank you. Thank
Thank
you.
you
My
so
pleasure.
much, sir,
Thank
for your
you.
precious time.
Thank you.
Thank
Thank
you,
you.
sir.
Bye bye. Bye bye.